Guys, this is Charity Stanley, and this is the second part of the renal lecture. So now we're talking about polycystic kidney disease. This is a genetic disorder that cysts fill up with fluid and develop within the kidneys, and these cysts rupture. And when the cysts rupture, it leaves empty space where the fluid-filled cysts once were. Kidney enlargement is one of the key characteristics of polycystic kidney disease, and patients with polycystic kidney disease often experience hypertension and they feel abdominal pain due to the cyst. The cyst may bleed, causing blood within the urine. Kidney stones are common with polycystic kidney disease as well. And the kidneys themselves look like a bunch of grapes, where each of the individual grapes is a cyst that's filled with fluid and will rupture, leaving empty space in its wake. So, control of high blood pressure is one of the most important things you can do to prevent kidney ischemia. So the cyst can happen also within the liver and within the blood vessels, and they're commonly associated with cerebral aneurysms and kidney stones. So this is an autosomal recessive condition, and frequently kids with polycystic kidney disease often die during childhood because their body can't filter the waste products. So, depending on which type of polycystic kidney disease, it can be autosomal dominant or it can be autosomal recessive. Most commonly is autosomal dominant polycystic kidney disease. And there's really no way to prevent this. The key is early management and helping the kidneys to be able to bounce back from the different cysts that are within the kidney. So, assessment of polycystic kidney disease. It's important to examine family history, find out if there's any kind of history of kidney disease. Pain is often one of the first symptoms. The kidney will start to swell, and this will cause abdominal distension. And often the patient will complain of a sharp, intermittent pain within the flank with the cyst rupturing. So the urine right after the cyst ruptures will often be bright red or cola colored with the rupture of the cyst. People with polycystic kidney disease don't concentrate urine as well. So at night, they tend to be up peeing a lot. The fancy word for that is nocturia. Often patients will complain of having a severe headache. This is related to a berry aneurysm, and this is a severe headache with or without vision changes. Now, any headache needs to be seen because these can rupture and cause bleeding within the brain. How do we diagnose this? This is often through looking at the kidney through an ultrasound, through MRI or CAT scan, and doing a urinalysis. Our urinalysis results will show increase in red blood cells. It will show a decrease in glomerular filtration, and we'll have an increase in protein that's being dumped in the urine as well. Now, our blood test will show a decreased GFR, and our kidney is upset, so we will have an increase in creatinine and an increase in the BUN. So big factors to look at when examining polycystic kidney disease is it's very important to manage the blood pressure. Take on a 2 gram of sodium diet. So this is a DASH diet that's very low in salt, low in calories as well, and decreasing weight will also help blood pressure. Managing pain, you want to avoid aspirin and apply dry heat like a heating pad to the flank area. Preventing constipation. The more bearing down that you do, the more likely you are to rupture the cyst on the kidneys. Make sure that patient is drinking adequate fluid, 2 to 3 liters a day, and taking stool softeners to make sure that they are not experiencing constipation. And then we need to make sure that the patients have adequate fluid as well. So hydronephrosis is a problem with urine elimination. And so with hydronephrosis, the kidney enlarges due to a backup of urine that can't escape. Hydroureter is where the stone is blocking the removal of urine from the kidney and the ureter into the bladder. And hydroureter is where the ureter itself expands and swells. Hydroureter will eventually cause hydronephrosis. So big keys to examine is childhood urinary tract infections may be relevant. If the urinary tract infection isn't recognized quickly and treated appropriately, it can cause damage within the ureter or within the kidney. And so diagnostic criteria often includes ultrasound or CT to be able to see the obstruction and to be able to measure the kidney and the ureter to see if there is hydronephrosis within the kidney or if the patient's experiencing hydroureter. Interventions. We can do a urologic intervention looking for stones, remove the stones and place a stent so that ureter doesn't recollapse. Radiologic interventions can look for a stricture, and we can put in a nephrostomy. And this is a tube that will drain externally to make sure that the pressure is relieved within the kidney and or the ureter. To do these procedures, we need to do prior clotting studies to make sure our patient isn't going to bleed. We need to arrange for sedation, look at placing a drain. The drain needs to remain open until the obstruction is removed. So we need to also monitor the patient for dehydration and make sure that there isn't a poor smell coming from the drain that could be indicative of infection. Renovascular disease. This affects the blood flow to the kidneys and is due to narrowing within the renal arteries. This often happens with patients who have no family history of hypertension, that for whatever reason, suddenly their renal arteries decrease in size and due to vasoconstriction. And it happens quickly with a sudden onset of hypertension resulting from renal stenosis. So key features is going to be difficult to control hypertension. Diabetes is going to make this worse. And your kidney levels are going to produce increased creatinine, increased BUN, and a decreased GFR. So the diagnosis is made through ultrasound or through magnetic resonance angiography, looking at it through radionucleotide imaging or arteriograms. So we need to find out where the narrowing is and how much damage has happened to the other blood vessels. We can also use medications to control the hypertension, and we can also redirect the blood flow. That's a renal artery bypass surgery. Diabetic nephropathy. This is a main complication of diabetes affecting the kidney. It's a leading cause of chronic kidney disease worldwide. Now, severity is going to be based upon the level of the hyperglycemia, and management is going to be the same as chronic kidney disease. Renal cell carcinoma. This is an adenocarcinoma of the kidney, most common type of kidney cancer. So it's usually accompanied by paraneoplastic syndrome. So what that's going to look like is we're going to have an increase in our liver enzymes, an increase in the SED rate, and a new onset of hypertension. Often it will metastasize to the adrenal gland, the liver, bones, or the other kidney. So it impairs elimination for the kidney that is affected, and eventually it can go on to infect the other kidney as well. Big things to recognize: you need to find out about smoking. Smoking is one of the most common risk factors, and so it causes a dull, aching pain. And one of the main treatments is going to be chemotherapy or surgery. So don't worry about the specific different types of renal cancers. We just need you to know about renal cancer in general. So the big key is going to be preventing metastasis and non-surgical management of this. So what we can do is we can kill the blood vessels, ablate the blood vessels to stop the growth, do directed chemotherapy, and we can also use biologic response modifiers to be able to non-surgically manage the renal cancer. Surgical management: we can take that kidney out, it's a nephrectomy. So the side with the kidney, when our patient positioning for surgery, the side with the kidney to be removed needs to be towards the ceiling. So radical removal takes lymph nodes too, in case the lymph nodes have been infected with renal cancer cells. We have to monitor for hemorrhage, monitor our blood pressure for low blood pressure and infection, monitor the vital signs frequently, check to make sure that the other kidney is going to be able to handle the increased workload. And pain management needs to be with opioids. Patients often have problems making urine immediately after this surgery and may show signs of adrenal insufficiency as well. Kidney trauma can be caused by penetrating wounds, being stabbed in the back, can be caused by blunt injuries, for example, car wrecks or being hit as a pedestrian by a car. And so a CAT scan is needed, and we need to check the blood to see what's going on. Big thing is examine the mechanism of injury, figure out how much pain the patient's in, learn how to assess for that pain, do a urinalysis to look to see how the urine looks, do an H&H to see if there's any internal bleeding. Ultrasound and CAT scan can also help us determine if there's any internal bleeding as well. So non-surgical management, we can just watch what's going on and examine the symptoms. We may have to replace the blood components that are being lost. We may need to use different kinds of IV fluid like lactated ringers, because it actually is a plasma expander depending on the amount of blood that's being lost. Or we can go into interventional radiology and repair the kidney or place a stent. So surgical management is the most intensive, and this is where we actually take out the kidney. So with kidney traumas, we're often going to see symptoms such as fever, patient's going to be very lethargic, and very cloudy urine and foul smelling urine because the urine is not being concentrated and made appropriately. So if we see any signs of infection or complication, then we'll notify the physician to ensure that our patient has the best care possible. Okay, that's the end of this, and I will see you in the next lecture. Thanks. Bye.